Welcome back to the deep dive. Today we are undertaking a really critical mission, diving headfirst into the foundations of surgical practice. This isn't just a review. It's an intensive, interpretive deep dive focused on mastering one of the most vital chapters in all of surgery.
It really is foundational.
We're talking about Chapter 3 of the 28th edition of Baily and Love's Basic Principles, the essential guide to wound healing and tissue repair.
This chapter is, it's the language of surgery. It dictates everything from how we place an incision to how we manage, a devastating burn.
Absolutely.
Our mission today, for you the learner, is to provide the ultimate revision guide and ready reckoner. We're going to unpack the dense pathophysiology, anchor the complex cellular details, and provide the clinical why behind every single management principle.
And we really have to stress this. This deep dive is meant to be a shortcut, an organized analysis using mental anchors and case studies to help your memory and comprehension. But the true, necessary depth still lies in reading the original text. We're giving you the scaffolding to make that reading faster and, frankly, more effective.
Okay, so before we get into the clockwork mechanisms of healing, we have to set the biological framework.
Yeah.
What is the fundamental, often overlooked truth about how adult human bodies respond to injury?
I think the text makes a stunningly clear and maybe a slightly discouraging point. Adult human healing is, almost universally, a story of fibrosis and scar formation.
Exactly.
The immediate priority is stability, not restoration.
Exactly. Scar tissue is the body's compromise.
Right.
It provides structural integrity, it holds the patient together, but it achieves this at the cost of functional efficiency. Scarring, by its very definition, is dysfunctional.
Which is why the whole field of regenerative medicine is so fascinating.
It is, because it focuses on that miraculous exception, early fetal healing, which somehow achieves perfect scarless repair, completely avoiding that fibrotic response.
It's the difference between a patch job and a factory replacement, isn't it?
That's a perfect analogy.
To help us map this complex sequence of events, let's introduce our primary anchor for the day. We are viewing the entire process through the lens of organized triage. Wound healing is the body's emergency response team.
A very good way to think about it.
The goal is survival and structural stabilization, and we are going to break down the 4 overlapping phases this team executes.
So we define 4 classically recognized overlapping stages. First, haemostasis, then inflammation, proliferation, and finally, remodeling.
Okay, let's unpack phase 1, haemostasis. This is the immediate, non-negotiable response.
This phase kicks off the moment the injury occurs, literally seconds after the cut. You get vascular smooth muscle contraction vasoconstriction to limit the initial blood loss.
Right.
But the real action is the exposure of the underlying subendothelial matrix, particularly collagen.
And that collagen exposure is the signal flare, isn't it? It's the instant call to action for the platelets. These are the initial architects forming that first mechanical plug.
The platelets are fascinating because they do 2 jobs at once. They form the plug, that's adhesion and aggregation, and more critically, they activate and release the signal molecules from their alpha granules.
Oh.
This is where the whole repair cascade really begins.
So if the platelets are the architects, the alpha granule contents are kind of like the construction blueprint. We're talking about hundreds of proteins, including those critical growth factors: TGF-beta, PDGF, FGF, EGF, and VEGF.
Right.
Why is it so vital to know what these specific letters stand for rather than just knowing their growth factors?
Because they determine the entire timeline. For instance, VEGF, vascular endothelial growth factor, that's the primary signal for angiogenesis, which is new vessel growth. That defines the next phase. And then you have PDGF, platelet-derived growth factor, and TGF-beta. These are the master switches. They are potent chemotactic agents that attract and stimulate the key cells of the next phase, the macrophages and the fibroblasts.
So without that alpha granule release, the emergency team just doesn't know where to go.
They're lost. The signal hasn't gone out.
So we have the initial platelet plug, but it's unstable. At the same time, the system needs to build a solid scaffolding using the coagulation cascade.
Right. Tissue factor, which is exposed by the damaged vessel wall, initiates the extrinsic pathway. This cascade is a rapid amplification loop that results in a massive production of thrombin.
And thrombin is a stabilizer.
Thrombin is the stabilizer. Its job is to convert circulating fibrinogen into insoluble fibrin. This fibrin mesh interlaces through the platelet plug, creating a structural scaffolding, a true, solid foundation.
And that's durable enough for the next wave of cells to move across.
Exactly. That step closes the immediate emergency. The bleed is controlled.
So now the focus shifts. Cleanup, defense, and preparation for construction. This is the inflammation phase, typically running from day 1 through day 3.
The early phase, so days 1 and 2, is dominated by the shock troops, the polymorphic nuclear leukocytes or neutrophils.
The first responders.
They're short-lived, highly aggressive phagocytes. Their primary immediate role is just to minimize bacterial contamination. They are the frontline defenders, protecting that new fibrin scaffold.
But then the shift on days 2 and 3 introduces the crucial cell that really runs the rest of the operation. This is where the arriving monocytes differentiate into the macrophages.
And these are the undeniable command cells of wound healing?
You can't overstate their importance, can you?
You really can't. Their functions are dual and absolutely essential. Role 1. They are the cleanup crew. They phagocytose cellular debris, damage tissue, spent neutrophils. Basically, they achieve chemical debridement by releasing potent proteolytic enzymes.
And role 2.
Role 2. They are the command center. They are the primary source of the later-acting growth factors and cytokines, specifically the ones that tell the fibroblast to start proliferating and the ones that encourage angiogenesis.
So if the macrophage fails to arrive or is impaired, say in a diabetic patient, the entire process just stalls right here.
It does. It gets stuck, keeping the wound chronically inflamed.
Which is what we see clinically.
Precisely. And clinically, the macroscopic appearance is the historical anchor for this phase. Rubor, redness, tumor swelling, calar heat, and duller pain.
The 4 classic signs.
These are all the visible signs of increased vascular permeability, cellular influx, and the release of inflammatory mediators like histamine and prostaglandins. These signs confirm that the emergency response team has fully arrived on site.
Okay, so once the site is clean and the signals are set by the macrophage, we enter the major construction phase, proliferation, lasting from around day 3 for several weeks.
The workforce is now the fibroblast. They are manufacturing the material for the new tissue, primarily ground substance, made of glycosaminoglycans and proteoglycans, and of course collagen.
And what we see clinically is the formation of granulation tissue. We've all seen it, that pink, granular, glistening look. What is that macroscopic appearance telling us about what's going on underneath?
It's a physical manifestation of high cellular activity. The pink color confirms angiogenesis, the budding and growth of new, fragile capillaries, which are providing oxygen and nutrients.
And the bumpy texture.
The granular texture is the ground substance and collagen being laid down by those hyperactive fibroblasts. It is the clearest visual indicator that the wound has successfully exited that destructive inflammatory phase and entered the organized construction phase.
And structural integrity starts to build up quickly here, relying initially on that quick and dirty patch collagen, which is type 3. But there's another specialized worker helping with stability, the myofibroblast.
The myofibroblasts are critical, especially for large, open wounds. They are specialized fibroblasts that acquire actin and myosin and become contractile cells.
So they literally pull the wound together.
They function like biological purse strings, actively pulling the wound edges together. This process, called wound contraction, dramatically reduces the size of a defect, especially in secondary intention healing. Understanding their role is absolutely key to understanding why large open wounds shrink over time.
Okay, then we get to the final and longest phase, remodeling. This overlaps with proliferation, starts around 2 to 3 weeks, but it can last for over a year.
It can. And the work is no longer about speed. It's about meticulous quality control.
What does that quality control mean at the molecular level?
It means the collagen swap. The provisional type 3 collagen, which has high elasticity but low strength, is systematically degraded and replaced by the rigid, highly cross-linked and aligned type I collagen. This is all mediated by matrix manaloproteinases, MMPs, and their inhibitors, TIMPs.
And the structural goal here is returning the collagen ratio back toward the normal dermal ratio, which is approximately 4:1, type 1 to type 3.
That's the goal.
So what does this maturation process mean for the strength of the wound over time?
This brings us to one of the most critical takeaways, what I call the 80% rule. Tensile strength increases rapidly during the first 12 weeks, driven by that cross-linking and type I deposition. But after that peak, even after a full year, the maximal strength achieved is only approximately 80% of the strength of the original uninjured skin.
So it's a permanent structural ceiling. It never gets back to 100%.
Never. That 80% ceiling is a fundamental limitation of adult repair.
Okay, let's do a quick check-in for understanding for you, the listener. You're reviewing a post-operative patient on day 10. The surgeon reports that the wound is showing excellent contraction, meaning the edges are pulling together nicely and it's firming up well. But the final scar needs to be minimized. If contraction is progressing effectively, which specific cell is driving that physical pulling action?
The cell driving that pulling is the myofibroblast.
And why should the surgeon worry that too much contraction might compromise the final outcome?
Because while contraction is beneficial for closing large defects, too much of it, especially near joints or orifices like the mouth or eyes, results in a contracture, which is a functional disability.
Ah, okay.
This is why surgeons aim for minimal tension and meticulous closure to rely less on that natural contraction if function is paramount. If you struggle to recall the myofibroblast's unique function, please rewind to the proliferation section now.
All right. Moving beyond the skin, which heals by scarring, we have to recognize that specialized tissues, bone, nerve, tendon, have unique biomechanical and cellular requirements that profoundly change their healing pathways.
The core difference is mechanical. Skin is relatively static. Bone and tendon are subjected to massive forces, and nerves have to maintain complex electrochemical signaling. The demands are just different.
Let's start with bone healing. It occurs along two distinct pathways, secondary and primary. The vast majority of fractures heal via the secondary pathway, right?
That's right. Secondary healing is the default, non-operative response, and it's defined by the formation of an external callus. It begins like skin healing. A large hematoma forms, which initiates inflammation. This is then replaced by an intermediate tissue, the soft callus.
And what is the soft callus made of?
It's fibrocartilage produced by invading cells, and this is where bone healing really distinguishes itself from soft tissue.
Okay.
That soft callus undergoes endochondral ossification, meaning bone is formed on a cartilage template to become a hard callus, which is structurally woven bone.
So it's like a temporary rigid structural brace that you can see on an X-ray.
Exactly. It stabilizes the fracture site. And then finally, over many months, remodeling converts that woven bone into the stronger load-bearing lamellar bone.
But in orthopedic surgery, the goal during an RIF open reduction and internal fixation is often to achieve primary bone healing.
Primary healing is fundamentally different because it relies solely on intramembranous ossification. That's direct bone formation without a cartilage or callus phase.
And that requires two things.
Two non-negotiable things.
Yeah.
Perfect direct apposition of the fracture ends, and critically, absolute rigid fixation. The mechanical stability provided by plates and screws eliminates the need for that external callus.
So the key takeaway is simple. The presence of callus, soft or hard, is the sign of secondary healing. Its absence defines primary healing.
And if there is a persistent gap or motion at the site, secondary healing fails, and you get non-union, delayed union, or malunion.
Okay, now for nerve healing in the periphery.
Peripheral nerves have a remarkable capacity for regeneration, provided the injury isn't too severe. So, not a complete neuromesis. The initial response is actually degeneration.
That famous degeneration distal to the injury site is called Wallerian degeneration. What specifically happens distal to the break?
The axon and its myelin sheath fragment and break down, and all this debris is phagocytosed by macrophages and Schwann cells. Proximally, the axon only degenerates back to the nearest node of Ranvier.
So the key cellular response comes from the Schwann cells. They're the guides here.
They are the true guides. They proliferate and form these tubes called the bands of Bungner. These bands physically align and guide the regenerating axonal sprouts from the proximal nerve stump toward the distal target.
And this is mediated by neurotropism.
Yes, a chemical attraction from growth factors and hormones at the distal end. The rate is slow, though, about 1 to 3 millimeters per day.
That's a huge distance to travel, especially in the leg. What is the pathological consequence if those regenerating sprouts fail to find the bands of Bungner or just encounter too much scar tissue or inflammation?
They become disorganized. They grow in a haphazard, tangled mess that creates a painful, palpable lump known as a neuroma.
Right.
A neuroma is essentially an attempt at regeneration that has failed to find its proper path, resulting in chronic, often debilitating pain due to the disorganized growth of sensory fibers.
And finally, in this section, tendon healing. This introduces what you call the mobility dilemma.
It does. Tendons require strength quickly, but they also require motion to prevent them from seizing up in the surrounding sheath. The surgical balance is extremely fine.
So the desired route is intrinsic healing.
That's the one we want. This means the repair cells and nutrients are supplied internally, primarily through vincular blood flow and diffusion from the synovial fluid in the tendon sheath. And this is highly dependent on early, controlled active mobilization protocols.
And if that early movement is restricted, the body relies on the less desired pathway. Extrinsic healing.
Extrinsic healing involves inflammatory cells and fibroblasts invading the tendon from the surrounding tissue, from the sheath and peritendinous tissues. While it does heal the tendon, it forms strong, limiting fibrous adhesions between the tendon and the sheath.
Which severely restricts the gliding motion.
And you lose your range of motion. So the clinical takeaway is clear. Tendon management is a constant tension between two conflicting priorities. You must protect the repair with splintage to avoid rupture, but you must simultaneously move the tendon early and carefully to promote superior intrinsic healing and avoid those limiting adhesions.
It's a surgical tightrope walk.
It really is.
Okay, now that we understand the microscopic process, we can turn to the macroscopic clinical outcomes, the choice of closure, and what happens when that meticulous cellular sequence fails.
We classify closure into 3 types, and this dictates the extent of the subsequent healing phases.
So primary intention is the goal.
Always the goal. Clean wounds, minimal tissue loss, direct, tension-free approximation with sutures. This results in minimal inflammation, minimal contraction, and the best possible scar.
Then there is secondary intention. This is when we leave the wound wide open due to large tissue deficits, high contamination, or known infection.
Correct. Secondary intention is the body healing the hard way. It requires extensive tissue building via granulation, significant wound contraction by myofibroblasts, and finally, epithelialization from the edges.
So, because this involves prolonged inflammation and proliferation.
The final result is always a poorer, more visible, and structurally inferior scar.
And the intelligent compromise is tertiary intention, or delayed primary closure. Let's use a clinical scenario to clarify this for the listener.
Good idea.
A 55-year-old farmer presents with a deep, messy, lacerated wound on their thigh, contaminated with soil and manure. After thorough irrigation in the emergency room, you decide not to close it immediately. Instead, you pack it open and plan daily dressings. What's your rationale? What healing process are you relying on? And what is your desired future goal?
Okay, your rationale is the high risk of infection. It's a class 3 or 5 wound. By leaving it open, you are initially allowing healing by secondary intention, letting the macrophages clean house.
But that's not the end goal.
No, your desired goal is tertiary intention. If the wound looks clean and develops healthy granulation tissue after, say, 4 to 7 days, you can take the patient back to the operating room and perform a delayed primary closure.
And that converts the outcome from a large, contracted secondary scar into a much better surgically approximated scar.
A huge difference in the final result.
Healing is a delicate process, and deviations result either in stagnation or overexuberance.
That's right. Chronic non-healing wounds are those that fail to progress through the phases. They get stuck in a prolonged, low-grade, destructive, inflammatory state, often due to underlying systemic issues.
And the opposite is excessive scarring, the result of overenthusiastic production of type I collagen and ground substance. This is where we have to nail the distinction between two commonly confused conditions.
We must be clear on the architecture and boundaries. Hypertrophic scars are raised, red, and firm, but their collagen is arranged in a parallel fashion. And crucially, they do not extend beyond the boundary of the original wound.
And they usually regress over time.
Usually within 12 to 18 months. They're common in high-tension areas like the sternum or after deep second-degree burns.
Now contrast that with the real clinical challenge, the keloid scar.
Keloid scars are aggressive. They contain highly disorganized collagen, and their defining characteristic is that they extend relentlessly beyond the margins of the original injury or incision. They just keep going.
And they don't regress.
They do not regress spontaneously, which makes them notoriously difficult to treat. And they have a strong genetic and racial predisposition, being more common in individuals with darker skin pigmentation. That failure to respect the boundary is the key diagnostic anchor.
We mentioned systemic factors influencing healing. Let's not just list them. Let's explore the mechanism. How does a systemic disease like diabetes mellitus actually impede the emergency response team?
Diabetes is a perfect example of multifactorial impairment. High glucose levels impair macrophage function, so the command cell is compromised, slowing debridement and signal release.
Okay.
It also causes microvascular disease, leading to localized hypoxia and ischemia, which starves the healing tissue of oxygen and nutrients. And then neuropathy prevents the patient from detecting minor trauma, which leads to chronic pressure points and ulcers.
So the diabetic wound is often contaminated, hypoxic, and run by a compromised command cell.
A perfect storm for non-healing.
And what about smoking? Many patients dismiss it as just a habit.
Smoking is direct vasoconstriction due to nicotine. It causes localized tissue hypoxia, starving the wound of oxygen. Oxygen is essential for macrophage function and, critically, for the hydroxylation of proline and lysine, a key step in collagen synthesis. No oxygen, no strong collagen. Simple as that.
All right, let's move on to classifying the battlefield. The surgeon needs a standard language to communicate the degree of risk and contamination.
And since no single system captures everything, we use multiple layers of classification. The contamination classification is critical because it dictates our prophylactic antibiotic regimen and predicts the risk of surgical site infection, or SSI.
So class on, clean, is the gold standard.
It is. We're talking about an elective hernia repair, non-traumatic breast surgery where the skin is pristine, inflammation is absent, and tracts were not entered. The SSI risk is minimal.
Then class 2 is clean contaminated.
This involves a controlled entry into a tract respiratory, alimentary, or urinary, but without significant spillage. A standard appendectomy or cholecystectomy is usually class 2. We usually give prophylaxis because the potential for bacterial introduction is there, but the risk is moderate.
The decision-making gets tougher at class 3, contaminated.
Class 3 means high risk. This includes fresh, open, accidental wounds, major breaks in sterile technique, or gross spillage from the GI tract. And crucially, it also covers acute, non-purulent inflammation, like a stage 1 perforated appendix.
So antibiotic prophylaxis is mandatory.
Mandatory and often broader spectrum.
And finally, class 4, dirty.
Class 4 is where contamination is a certainty. This means old traumatic wounds over 6 hours old with devitalized tissue already present, or surgery performed in the presence of existing clinical infection, like an abscess or perforated bowel with established purulence.
And that requires aggressive antibiotics immediately.
Both prophylactic and therapeutic, yes.
The contamination class tells us about the wound itself, but the NNIS score tells us about the patient's overall vulnerability to SSI. It's a pragmatic index ranging from 0 to 3.
It simplifies the prediction of SSI risk by integrating 3 key measurable variables. A point is assigned for each one that's present. The first point is for the contamination, a class 3 or 4V wound. This acknowledges the bacterial load.
The second point is about the patient's underlying physiological reserve.
That is the ASA score being greater than or equal to 3. The American Society of Anesthesiologists score classifies patient fitness. A score of 3 means severe systemic disease, like severe COPD. This tells us the patient's body will be slower to mount an effective immune response.
And the third point accounts for the complexity and length of the surgical trauma itself.
That is the operative time being greater than the 75th percentile for that specific procedure. A longer operation means more exposure, more tissue handling, more desiccation. They're all independent risk factors for infection.
So a patient with an NNIS score of 3 has a vastly higher risk of SSI than a score of 0.
Massively higher. And that guides your post-operative surveillance and management.
With the battlefield classified, we move to the core toolkit of clinical management. Table 3.2 gives us the step-by-step approach, starting with the patient.
First rule, ATLS first, life before limb. The patient has to be stable before you address the wound details. But once they are stable, we look closely at the mechanism of injury.
And this is critical because some wounds can deceive the eye. Give us the prime example of a deceptively innocuous injury that demands immediate surgical exploration.
The classic example is the high-pressure injection injury of the hand. The entry wound is often just a pinprick, but paint, grease, or solvent is injected at hundreds or thousands of psi, and it tracks along fascial planes all the way up the forearm,
Causing massive internal damage.
massive mechanical injury, chemical inflammation, and ischemia. It requires urgent, wide surgical decompression and washout, or the limb is lost.
An absolute non-negotiable step before local management begins. Function testing. Why must motor and sensory function be documented before the local anesthetic block?
Because local anesthesia completely obscures the patient's ability to cooperate with motor testing and sensory mapping. You need to know if a nerve or tendon is severed before you numb the area. Otherwise, the diagnosis might be delayed by hours. It's a medico-legal minefield if you don't.
Right. Preparation also includes the tetanus imperative.
Absolutely. The decision to administer tetanus immunoglobulin versus tetanus toxoid is dictated by the wound risk and the patient's immunization status. If the patient is unimmunized and has a high-risk wound, they require both immediate TIG for passive protection and the toxoid for active long-term immunity.
It's a life-saving distinction.
It is.
And finally, before any surgical intervention, we need to reduce the bacterial load.
Irrigation is essential. Use warm, normal saline under pressure, not too high, to avoid driving bacteria deeper, but sufficient to mechanically wash out debris. This physical reduction of the bacterial count is often more important than the choice of initial antibiotic.
Okay, debridement. The source material is emphatic. Debridement is the most important intervention in acute wound care. If you leave necrotic, non-viable tissue behind, the emergency response team just cannot complete the job.
Surgical debridement is the ultimate intervention. It means sharp excision of non-viable tissue until you reach the endpoint of healthy bleeding tissue. In complex trauma, this often means taking the patient back to the OR for serial debridements until the wound bed is completely clean.
How does the surgeon assess viability in different structures in the field?
For skin, we look for punctate dermal bleeding. For fat, it has to be soft and yellow, not dull and firm. For muscle, often the most critical assessment, we judge viability by 4 criteria: color, consistency, capacity to bleed, and its ability to contract when stimulated.
And if it's dark and non-contractile?
If it's dark, non-contractile, and doesn't bleed, it is necrotic, and it must be excised to prevent massive infection and systemic sepsis.
Beyond the scalpel, the text lists 4 other methods of debridement. Let's quickly interpret their clinical utility.
Okay, mechanical debridement, like wet-to-dry dressings, is non-selective. It removes non-viable tissue, but it can also damage the fragile, desirable granulation tissue underneath.
So, effective but potentially harmful to the good tissue. What about the selective methods?
Autolytic debridement uses specialized dressings to maintain a moist environment, allowing the wound's own enzymes to break down only the necrotic slough. It's very selective and minimizes pain, but it's the slowest method,
And then there's enzymatic debridement.
which uses topical agents like collagenase to chemically dissolve specific components of the necrotic tissue. It's faster than autolytic, but still slow. And finally, the most surprising one, biological debridement.
The maggots.
Metal-grade Lucilia serracato larvae. They're incredibly effective because they achieve selective debridement by releasing powerful proteolytic enzymes that digest only necrotic tissue. And they also have antimicrobial properties, often used for wounds resistant to conventional methods.
Once the wound bed is clean and viable, we must close it. The golden rule must be repeated. Skin closure must always be tension-free.
Tension causes ischemia, ischemia causes failure, and a poor scar, period.
When direct closure isn't possible, we move to the reconstruction ladder. This is a hierarchy of options.
It is. NPWT is an adjunct, not a closure. Grafts and flaps are definitive reconstruction.
Let's anchor the difference between a graft and a flap. A skin graft is simpler, but highly vulnerable.
A graft is simply tissue that is completely severed from its original blood supply. It is entirely dependent on the recipient site, the wound bed being robustly vascularized. Its survival relies on the process of imbibition and then inosculation.
And we use split-thickness grafts for large areas like burns?
We do, but they are fragile. Full-thickness grafts contract less and look better, but they require a pristine wound bed to take.
The flap, in contrast, is the heavy-duty option.
A flap contains its own intrinsic blood supply, either random or defined by a vascular pedicle. Because it carries its own blood flow, it can survive over a poorly vascularized site like exposed bone, tendon, or hardware.
And a free flap is the most complex.
That's the pinnacle. Tissue detached from one part of the body and moved to a distant site, requiring highly specialized microvascular anastomoses to connect the vessels under magnification.
And what role does negative pressure wound therapy, or NPWT, play in this hierarchy?
NPWT is a conditioning tool. By applying subatmospheric pressure, it achieves several beneficial effects. It mechanically draws the wound edges together, it removes edema-inducing exudate, and it increases blood flow, promoting healthy granulation tissue.
But there are absolute contraindications that can be catastrophic if ignored.
Yes, you must not use NPWT where the negative pressure could damage underlying structures. Contraindications include exposed major blood vessels, risk of fatal hemorrhage node malignancy in the wound, untreated osteomyelitis, or in the presence of necrotic tissue that hasn't been debrided.
So it facilitates closure, but it is never a substitute for adequate surgical debridement.
Ever.
We move now into the realm of time-critical surgical emergencies. These are acute, high-morbidity conditions that test a surgeon's judgment and speed.
And first up is degloving injuries. These involve the massive avulsion of skin and subcutaneous fat from the underlying deep fascia caused by tremendous shearing forces.
Right.
The integrity of the flap's blood supply is immediately compromised.
Let's focus on the distinction between open and closed degloving.
Open degloving involves visible skin loss. Closed degloving, however, is deceptive. The skin remains intact, but the shearing force creates a large cavity beneath it, stripping the subcutaneous tissue from the fascia. This characteristic subcutaneous accumulation of fluid, blood, and lymph is the Morel-Lavalley lesion.
And that often requires drainage and fixation.
It does, because the flap is essentially non-viable and prone to necrosis and infection. Viability assessment is difficult, relying on serial surgical observation.
And that's why prompt aggressive excision is sometimes necessary, even if the skin looks okay initially.
Exactly. If the dermal layer is non-viable, it will quickly become necrotic and infected. In the worst-case scenario, multiplanar circumferential degloving primary amputation may be the only safe choice to prevent sepsis and preserve life.
Okay, now, acute compartment syndrome, ACS. The definition of a limb-threatening crisis.
It's a rapid spiral into tissue death. The pathophysiology hinges on a simple mechanical principle. Trauma causes swelling within a rigid, closed osteofascial compartment. This pressure increases until it exceeds the capillary perfusion pressure.
And when that happens, blood flow stops.
Blood flow stops, causing muscle ischemia and necrosis. Irreversible damage occurs very quickly.
Clinically, what is the cardinal, most reliable sign that should trigger an immediate code blue?
It is the pain out of proportion to the injury, especially pain caused by passive stretching of the muscles within that compartment. The limb might not look massively swollen at first, but that passive stretch stresses the ischemic muscles, causing agony.
And paresthesia is an early warning sign.
It is. But the absence of a pulse is a late sign. If you're waiting for that, you're too late.
How do we confirm the diagnosis if the clinical picture is unclear?
If a patient is unconscious, intubated, or has ambiguous symptoms, we have to measure the intracompartmental pressure, the ICP. The surgical threshold for emergency fasciotomy is when the difference between the patient's diastolic blood pressure and the measured ICP is less than or equal to 30 millimeters of mercury. This is the delta P.
And the treatment is an emergent fasciotomy. How is the crucial two-incision approach performed in the lower leg to ensure full decompression?
To reliably decompress all four compartments of the lower leg, surgeons use a two-incision approach. A long axial incision is made medially, decompressing the superficial and deep posterior compartments. Then a second long axial incision is made laterally, decompressing the anterior peroneal compartments. Both skin and deep fascia must be incised.
Okay, necrotizing fasciitis, NF. If ACS threatens the limb, NF threatens the life.
It does, with a mortality rate that is shocking, up to 40% in high-risk groups. It is the most aggressive soft tissue infection we know.
It's often polymicrobial, but the monomicrobial type 2, group A strep, is perhaps the most rapidly devastating. The common thread is the speed of systemic decompensation.
And diabetes is the single most common predisposing factor. The diagnosis is often subtle initially. The key anchors are systemic toxicity, sepsis, shock, multi-organ failure, and the local signs.
That local pain being out of proportion is critical again. What are the definitive visual signs?
Look for skin findings that progress rapidly from erythema to bullae formation. You might feel crepitus gas production from anaerobic bacteria felt under the skin, and the classic unmistakable discharge. A grayish drainage, often described as dishwater pus.
And when you see that, you don't need any more investigation.
None. The book emphasizes this. NF is a clinical diagnosis. Do not delay waiting for lab results or complex imaging.
What is the immediate life-saving management?
Immediate, radical surgical debridement. This means wide excision of all necrotic skin, fat, and fascia until you reach healthy bleeding tissue, combined with aggressive broad-spectrum IV antibiotics.
And there's a mandatory second look operation.
Always. Within 24 to 48 hours to confirm the infection is controlled and no more tissue requires removal.
Okay, let's run a quick clinical scenario to cement these concepts for you, listener.
Let's do it.
A 40-year-old patient is 48 hours out from a routine operation, let's say a simple appendectomy. They report severe, constant pain that is not relieved by adequate post-operative morphine. Their incision looks only mildly red, but when the nurse moves their leg for a bed change, the patient screams in agony. Furthermore, you note their heart rate is 120 and their blood pressure is trending down. What two surgical emergencies jump to the top of your differential diagnosis, and why must you bypass imaging and act immediately for both?
The combination of systemic unwellness, tachycardia, pain disproportionate to skin findings, and that exquisite pain on passive movement are massive red flags for acute compartment syndrome and early necrotizing fasciitis.
ACS and NF.
Absolutely. And you must act immediately because ACS causes irreversible muscle death in a matter of hours, and NF leads to sepsis and death in a matter of days. Delaying surgical exploration for either of these guarantees irreversible morbidity or mortality.
We shift now from crisis management to the long game managing wounds that are either stuck in a chronic loop or the structural outcome of the initial repair?
Chronic ulcers represent a failure of the healing process. They are structurally characterized by peripheral fibrosis, prolonged low-grade inflammation, and the presence of slow necrotic tissue in the wound bed.
And management is always about addressing the underlying etiology, which is most often vascular.
Venous insufficiency, arterial disease, or mixed. But this is perhaps the most important clinical anchor in this section. Any chronic ulcer that has been present for years, especially one that is suddenly changing, must be immediately biopsied.
We are looking for malignant transformation.
Yes, we are looking for Marjolins ulcer, a squamous cell carcinoma arising within the chronic, non-healing wound or long-term burn scar. Failing to biopsy such a lesion leads to a devastatingly delayed cancer diagnosis.
Okay, pressure injuries, formerly known as pressure ulcers.
The terminology has been updated by the NPIAP to pressure injuries to encompass injuries to intact skin as well as ulcerated tissue. They occur over bony prominences, sacrum, ischium, heels.
And we have to know the staging. Stage 1 is non-blanchable redness. Stage 4 is full thickness loss involving muscle or bone. We also have unstageable injuries and deep tissue pressure injuries, or DTPIs.
Right, which manifest as that non-blanchable deep red or maroon discoloration under intact skin, indicating deep damage.
The primary focus must always be prevention.
Always. We have validated risk scales. Braden, Waterlow, Norton, and preventative measures are simple but essential. Regular repositioning every 2-4 hours and pressure redistributing devices.
Surgical management is complex and reserved for failures of conservative care. Why are primary closure and simple skin grafts largely contraindicated and likely to fail in pressure injuries?
Because the underlying cause, pressure, and poor perfusion over the bone is still present. A skin graft will simply fail due to lack of blood supply, and primary closure will break down under tension.
So successful surgical management relies on rotating in large, robust, well-vascularized tissue.
Specifically, fasciocutaneous or musculocutaneous flaps, which can fill the dead space and provide a healthy, well-padded tissue layer over the bony prominence.
All right, principles of scar management. The final result of the 80% rule is the scar.
And we have to understand the maturation process. It's a slow burn, 1 to 2 years. The scar transitions from immature, pink, hard, itchy, to mature, pale, soft, pliable. But the tensile strength maxes out at that 80% ceiling.
So prevention is the bedrock of good plastic surgery.
Meticulous technique, placing incisions along relaxed skin tension lines, avoiding straight lines across joints, and precise layered closure.
And layered closure is key to minimizing tension on the surface.
It is. We use deep dermal absorbable sutures to hold the structural tension. The skin surface sutures are then only for accurate approximation, and their removal timing is crucial. Quick, maybe 5 days on the face, and slower, 10-14 days on the lower limb.
What is the undisputed first-line prophylaxis and non-surgical treatment for both hypertrophic and keloid scars?
Silicone sheeting or gel. It works primarily by occlusion, increasing hydration and temperature, which is allowed to reduce collagen production. This is the first step in the management algorithms.
And if silicone fails, we escalate.
To intralesional corticosteroids, typically triamcinolone acetonide. The steroid acts as a powerful anti-inflammatory, reducing fibroblast activity and collagen synthesis. These injections are repeated every 4 to 6 weeks until the scar flattens.
The most functionally devastating outcome of scarring, particularly after burns, is the contracture.
A restriction of movement across a joint. Contractures result from the scar tissue shrinking and pulling the soft tissue across the joint line. The primary surgical principle for release is to excise the scarred tissue and replace it with better, more elastic, well-vascularized tissue.
When dealing with a linear scar contracture, like one running straight across a finger joint, what is the classic local flap technique used to lengthen the scar and break up that line of tension?
That is the Z-plasty and its variants. By designing 2 triangular flaps and transposing them, the surgeon effectively lengthens the scar along its axis while breaking the tension line, thus restoring movement.
And when resurfacing a large contracture defect, we have to revisit our graft discussion. Why does the text favor full-thickness skin grafts over split-thickness grafts for functional areas?
Because split-thickness grafts undergo significant secondary contraction during the remodeling phase, sometimes up to 50%. A full-thickness graft, because it contains the majority of the dermal layer, contracts significantly less, providing a better long-term functional result and a better aesthetic match.
All right, let's wrap this up.
We have executed the entire journey from the molecular triage performed by the emergency response team at the moment of injury, through the specialized repairs in bone and nerve, to the long-term clinical challenge of managing the end product, the scar. Mastering this chapter gives you the foundational language and judgment necessary for every single subspecialty of surgery.
Let's review those critical anchors we've established for your Ready Reckoner today. First, remember the primary anchor. Wound healing is the body's emergency response team, defined by the 4 overlapping phases: haemostasis, inflammation, proliferation, and remodeling.
Remember the 80% rule. Maximal tensile strength is capped at about 80% of uninjured skin even after a year, reflecting the permanent structural compromise of adult healing.
Remember the macrophage is the undisputed command cell of the inflammatory and proliferative phases, managing both the cleanup and signaling the start of construction.
Remember the distinction between abnormal scars. Hypertrophic stays contained within the boundary, while the dreaded keloid extends aggressively beyond it.
And finally, remember the difference between primary versus secondary bone healing. The presence or absence of the soft and hard callus is the defining factor, dictated by the stability achieved at the fracture site.
These concepts must be automatic. Use this deep dive, but please, go immerse yourself in the full detail of the foundational text.
We anchored the idea that adult healing is limited to the 80% rule because of fibrosis, whereas fetal healing avoids it completely. If regenerative medicine research, which seeks to mimic that fetal scarless repair, succeeds in developing a therapy that fully inhibits fibrosis, what is the single most revolutionary change this would bring to managing massive complex injuries, like full-thickness burns covering half the body, or multi-fragment crush fractures that currently rely on internal fixation and callus starmation?
It would eliminate the need for skin grafting entirely, restore 100% tissue strength, and fundamentally change orthopedic reconstruction by replacing unstable woven bone with perfect lamellar bone directly, effectively eliminating non-union. That is the ultimate goal.
A future where the body truly rebuilds, not just patches. Thank you for joining us for this crucial deep dive.
Until next time.